Dear students, I welcome all of you to this discussion module on the dermatology questions which appeared in the AIIMS 2020 examination. Let's take up the question number 1. So question number 1 is about a patient who is a known case of chronic plaque psoriasis with more than 50% of skin involvement presents to you. What of the following options you will not recommend? So always pick up this word not recommend. A. Methotrexate, B. Narrowband UVB, C. Oral steroids, and D. Cyclosporine. So in a patient of chronic plaque psoriasis, it's a straightforward question in the exam. The answer to this question is oral steroids. Now, what is the status of oral steroids in psoriasis? So number 1 is, first you remember that oral steroids are contraindicated in psoriasis. So this is point number 1. So oral steroids are contraindicated in psoriasis. What is approved in psoriasis is topical corticosteroids. So topical corticosteroids are used because of its anti-inflammatory properties, but oral steroids are contraindicated. Now, what is the reason? Why are oral steroids contraindicated? Because generally when you stop oral steroids in psoriasis, it can trigger severe forms of psoriasis like erythrodermic psoriasis, and pustular psoriasis. So it can trigger more severe forms of psoriasis like erythrodermic psoriasis and pustular psoriasis. So there is one exception to this rule of oral steroids. The only indication in psoriasis where oral steroids can be given is termed as PPP. So what does PPP stand for? It stands for pustular psoriasis of pregnancy. It stands for pustular psoriasis of pregnancy. This is a very important question in the exam. This condition is also known as IH, which stands for impetigo herpetiformis. Impetigo herpetiformis. So the other name for pustular psoriasis of pregnancy is impetigo herpetiformis. So this is the only indication where systemic steroids can be used in psoriasis. Now let's quickly go through the treatment of psoriasis, which is classified based on the body surface area. If it is less than 10% body surface area, we can obviously go for topical therapies. If there is more than 10% involvement, we have to go for number 1, phototherapy. So we can go for phototherapy, or we may have to go for systemic drugs. We can go for systemic drugs. So the question says more than 50% of the body surface area. So we have to go for systemic therapy. So option number A was methotrexate. So what is the status in psoriasis? Methotrexate is used in chronic plaque psoriasis more than 10% body surface area. It can be used in the erythrodermic variant of psoriasis. It can also be used in psoriatic arthritis. So these are important indications. What is the mechanism of action? How does it work? So it inhibits dihydrofolate reductase enzyme. So it is responsible for inhibition of this enzyme, dihydrofolate reductase, which is responsible for the conversion of dihydrofolic acid to tetrahydrofolic acid. So this particular step is blocked by methotrexate, and it acts on the S phase of the cell cycle. So of the cell cycle phases, it is going to act at the level of the synthesis of DNA phase. What are the important adverse effects of methotrexate? So very important is when I start the patient on methotrexate, when he comes for follow-up, I always ask for a CBC or a complete blood count. This is basically to rule out bone marrow suppression. So this is number 1, bone marrow suppression. We also ask for an LFT because methotrexate is hepatotoxic. So it's a hepatotoxic drug. And third point is it should not be given in a childbearing age group because it is teratogenic drug. So it's a category C, it's a teratogenic drug. Let's look at the other options here. Cyclosporine, the status in psoriasis is it is a drug of choice for severe erythrodermic psoriasis. So the drug of choice for severe erythrodermic psoriasis is cyclosporine because it acts very rapidly and can bring down psoriasis very quickly. What is the mechanism of action? So it basically inhibits calcineurin. So it is inhibitor of calcineurin. And when I start a patient on cyclosporine, when the patient comes for follow-up, number 1, what do? Is I record his blood pressure because one of the most important side effects is hypertension. And I always ask for a renal function test because just like I told you, methotrexate is hepatotoxic drug, cyclosporine is nephrotoxic drug. So nephrotoxicity is important. Then it can also produce side effects like gingival hyperplasia. Gingival hyperplasia can also be a side effect of long-term usage of cyclosporine. We move on to the second question. A farmer presents with swollen foot and multiple sinuses as shown in the image. What is the most likely diagnosis? So what do we see here is you see that there is swelling. You can see that there are sinuses as well. So whenever a patient is there who's going to present with a swollen foot and multiple sinuses, the correct answer has to be mycetoma. So mycetoma is the diagnosis. So what is mycetoma? So mycetoma is classified as a subcutaneous mycosis. And for this subcutaneous mycosis, it is broadly classified into two, eumycetoma and actinomycetoma. So this is the broad classification. In eumycetoma, the implicated organism is going to be fungus. Actinomycetoma are produced by bacteria. It's produced by bacteria. And how does mycetoma present? Now mycetoma is going to present as a triad. So number one, it is going to present with swelling, which is called as tumefaction. So tumefaction means tumor-like swelling. So this is point number one. Point number two is the presence of multiple sinuses. So it presents as multiple discharging sinuses. And number three, from the sinuses, what is going to happen is you are going to get discharging granules. So what are these granules? These are basically the colonies of the organism, and based on the color you can identify whether it's eumycetoma or actinomycetoma. In a patient of eumycetoma, you're going to get dark color granules or black color granules. In a patient of actinomycetoma, you're going to get the pale colored granules, cream or whitish granules. So there are exceptions in both categories, but generally you remember the darker colors are for eumycetoma, the paler colors are for actinomycetoma. Now one of the options was sporotrichosis. Now sporotrichosis is also called as rose gardener's disease. It's termed as rose gardener's disease. And here what happens, how does the organism enter? It enters via a thorn prick. So once it enters via a thorn prick, we already know the organism is Sporotrichotystrophy. It is going to produce a nodulo-ulcerative lesions. So you get nodulo-ulcerative lesions which are going to be linear in distribution. That is because this organism is going to target the lymphatics of the upper extremity. So the lymphatics of the upper extremity get targeted, resulting in the presence of linear nodules along the upper extremity. We take up the third question. A young male presents to the STD clinic with painful lesions. So the first point to remember is painful lesions. Which of the following is the most likely microscopic finding of the lesion? So let's analyze this question once again before looking at the options. So number one is you know that the lesions are painful. Number two, you see these lesions here, isn't it? What are these lesions? These are vesicles. These are vesicles. And if you look at the arrangement of this lesion, very, very important. What is this arrangement termed as? This is termed as grouped lesions. So you're seeing that there are vesicles and there is a configuration of grouped in nature. So this is going to lead to the diagnosis of genital herpes. The diagnosis here, when a patient presents to an STD clinic with grouped vesicles which are painful, the diagnosis has to be genital herpes. So now the correct answer with in mind that it's genital herpes has to be the multinucleated giant cells, which is the answer for this question. So we all know that genital herpes is produced by HSV2, which is more common than HSV1. The most common organism has to be HSV2, and we get vesicular lesions in genital herpes. So whenever there's a vesicle, what investigation do I want to do? I want to do a Zank smear. And what will be the findings of this Zank smear? Two important findings to remember. Number one is the presence of multinucleated giant cells. So this is the first important finding to remember. Second important finding is you can also get acantholytic cells. Can also get acantholytic cells, which are also referred to as Zank cells. Because acantholytic cells are modified keratinocytes which occur in a patient of genital herpes. Now, the most common mistake which was made by students is they confuse these lesions for these lesions. Now, what are these lesions? The most important differential diagnosis here is molluscum contagiosum. Molluscum contagiosum. Though it's more common among children and MCV1 is the most implicated etiology, it can also be seen in adults. You can also get it in adults, and here MCV2 is the most common strain which is implicated here. Now, what are the points against molluscum? So number one, the question says painful. Molluscum lesions are not painful. So this is point number one. Point number two, in molluscum contagiosum, you're going to get papules. Okay, we already know the description of these papules. They are pearly white, dome-shaped and umbilicated. So pearly white, dome-shaped, umbilicated papules, which sometimes can be difficult to make out, but very important is you can appreciate the erythema which is there around the lesions. So here you can see there is no perilesional erythema. No perilesional erythema. So that is yet another point which goes against molluscum. So the molluscum lesions are not painful. The lesions are papular and no perilesional erythema. These are the important points which exclude molluscum contagiosum. Option B is Greenblatt and Punt cells. So only Punt cells was mentioned. So what are these Greenblatt cells? These are large mononuclear cells. So these cells over here are called as Greenblatt and Punt cells. And how do you identify them? You see this is the nucleus which is eccentrically placed. So we have an eccentrically placed nucleus. And if you carefully see what you see inside, here what you see is, you see organisms which are arranged in this characteristic pattern, where there is bipolar condensation of chromatin, and these are called as Donovan bodies. So these are called as Donovan bodies. These are termed as Donovan bodies. So this particular Greenblatt and Punt cells are a feature of granuloma inguinale, and very commonly it's also called as donovanosis. Now at this juncture I want to tell you another question which was asked in last year's exam. Donovanosis is produced by, and most of the students got it wrong, they marked it as Leishmania donovani. Please understand, Leishmania donovani produces leishmaniasis. Donovanosis is produced by Klebsiella granulomatis. Klebsiella granulomatis is the organism for donovanosis. Option C was Henderson-Patterson bodies. So what are these bodies? You can see them. They are eosinophilic. So point number one, they are eosinophilic. Point number two, the inclusion bodies are inside the cytoplasm. So they are intracytoplasmic. They are intracytoplasmic inclusion bodies. And these eosinophilic intracytoplasmic inclusion bodies, called as Henderson-Patterson bodies, are very characteristic of molluscum contagiosum. So they are a feature of molluscum contagiosum. So that's an important point to remember. And option D, Halber-Stedler-Provezek bodies. These are seen in chlamydia infection. So chlamydia trachomatis. So chlamydia trachomatis produces characteristic bodies which are termed as Halber-Stedler-Provezek bodies. We go to question number 4. Which of the following is true about Chancroid? So let's go option by option. So number 1, school of fish appearance. Is it true or false? Yes, it's a true statement. That's because Chancroid is produced by Haemophilus ducreyi. So here you get gram-negative cocobacilli. So gram-negative cocobacilli are seen. So these gram-negative cocobacilli are arranged parallelly to result in either school of fish appearance. So this is one appearance. This is also referred to as railroad track appearance. Also known as railroad track appearance. So school of fish appearance is number 1. Also referred to as railroad track appearance. Bleeds on touch is also a true statement. Painful. Yes, this is also a true statement. What about groove sign? Now groove sign is the false statement. It's because groove sign is produced by Chlamydia trachomatis as a manifestation of lymphogranuloma variolium. So in lymphogranuloma variolium you get groove sign. So what is the answer here? A is correct, B is correct and C is correct. That is why the correct answer here is going to be ABC only. Now let us learn something about chancroid. Now chancroid is also known as soft sore. Chancroid is also known as soft sore, whereas chancre, which is seen in syphilis, is called as hard sore. So what are the distinguishing genital ulcer lesions which you get in chancroid? So you get a genital ulcer here, which are usually multiple. You can see in the image you get multiple ulcers which are necrotic based. The second point is they are necrotic based. Third important point is that's why it is called soft sore, because they are non-indurated. They are non-indurated, tender, and they bleed on touch. So these are the 5 important features which you should remember for a chancroid ulcer produced by Haemophilus ducreyi. Now, what is groove sign, which I just mentioned to you? So this is the inguinal ligament, and you can see enlargement of the lymph nodes above and below the inguinal ligament. This is called as groove sign of Greenblatt. This is also termed as groove sign of Greenblatt, which is seen in lymphogranuloma venereum produced by Chlamydia trachomatis L1, L2 and L3. So Chlamydia trachomatis L1, L2, L3 produces LGV. Now, how we should approach a question of genital ulcer disease, because you can see in this particular INICET there were 4 questions from STD, so this becomes very, very important. So whenever there's a question on genital ulcer disease, you classify it like this: are the ulcers single and non-tender, or are the ulcers multiple and tender? So once you made this broad classification, you can easily divide the STDs, because there are 5 important STDs which produce genital ulcer. So when you say single and non-tender, there are 3 diseases in this category. And when you say multiple and tender, there are 2 diseases in this category. So let's take up the first category, which is single and non-tender. So once single and non-tender is mentioned, then what you do, you examine the inguinal lymph nodes. Now, if the inguinal lymph nodes is mentioned as normal, then the diagnosis becomes donovenosis. We already know this presents as beefy red granulation tissue which bleeds on touch. So this we are already aware of in donovenosis. Suppose if the question says bilateral enlarged non-tender lymph nodes, then the diagnosis is going to be syphilis. And if it mentions as there is a bubo formation, then the diagnosis is LGV, because we should know that whenever there is ulcer in LGV, it is painless, transient ulcer. That is why usually it is not noticed by the patient, and it can be herpetiform. So the ulcer which is seen in LGV can be painless, transient and herpetiform ulcer. That's why most of the times patients will not notice this ulcer, because it's a transient ulcer. The second category, when we discuss the second important category here, you're going to have multiple tender ulcers. So in this multiple tender ulcers, number 1, if they are bilaterally enlarged and tender inguinal lymph nodes. So if the inguinal lymph nodes are bilaterally enlarged and tender, the diagnosis becomes genital herpes. And if the lymph nodes, it's mentioned as bubo. So what is a bubo? Bubo is a enlarged pus-filled lymph node. It's an enlarged pus-filled lymph node, which is termed as bubo, and here the diagnosis is going to be chancroid. So genital herpes and chancroid are basically distinguished based on the lymph node properties. We go to question number 5. Which of the following presents with painful genital ulcer? So let's go option by option. So number 1, Haemophilus ducreyi. Let us see what disease it produces. It produces chancroid. Neisseria gonorrhoeae produces gonorrhea. Chlamydia trachomatis L1, L2, L3 produces LGV. Herpes simplex virus produces genital herpes. Now let's see which is painful. So chancroid is painful. Genital herpes is also painful. Gonorrhea is painful, but it produces urethritis. It is going to produce urethritis. That is why we have to exclude it out. That's why the correct answer has to be A and D only, because the answers are Haemophilus ducreyi and herpes simplex virus. Now look at the next question. The fourth question from STD. A 30-year-old male patient presents with urethral discharge. Gram stain is shown. Which of the following could be the most likely diagnosis? So what is shown over here is, you can see neutrophils. Right? You can see a lot of neutrophils, and you can see inside the neutrophils what you see here is you get gram-negative diplococci. Gram-negative diplococci are seen, and these gram-negative diplococci are inside the WBC. They are intracellular inside the WBC. So that is why this goes in the favor of Neisseria gonorrhoeae. So Neisseria gonorrhoeae is a gram-negative organism, and that's why the correct answer here is Neisseria gonorrhoeae. What does Gardnerella vaginalis produce? It produces bacterial vaginosis. Going to produce bacterial vaginosis. Trichomonas vaginalis produces trichomoniasis. So this year there's been no question from vaginal discharge. So see that you know these topics well, because Trichomonas is going to produce this strawberry cervix. That's one question to remember. And this greenish yellow vaginal discharge. That's an important point to remember. And bacterial vaginosis is diagnosed by means of clue cells, which is very, very important. For trichomoniasis, I told you, you have to remember strawberry cervix and greenish yellow vaginal discharge. Greenish yellow vaginal discharge. We take up the next question. So before that, let's look at the presentation of gonorrhea. So here what you see is purulent, profuse discharge. So what you see here is presence of profuse purulent urethral discharge, and this microscopic image you have already seen. And what is the treatment of gonorrhea? Very important to remember is we have to give dual therapy. So first is an injection, second is a tablet. You're going to give injection ceftriaxone 250 mg IM stat. So this is the first drug to be given. The second drug to be given is tablet azithromycin 1 gram stat. So very important to remember, we have to give dual therapy in gonorrhea. Question number 7. Which of the following is the gold standard for airborne contact dermatitis? Let's first look at the options which are given here. Number 1 is serum IgE. So where does serum IgE come in dermatology? Very important is serum IgE forms a minor criteria. So it's a minor point in the diagnostic criteria for atopic dermatitis. Now what is the name of the diagnostic criteria for atopic dermatitis? It is called as Hanifin and Rajka criteria. Is called Hanifin and Rajka criteria. So the Hanifin and Rajka criteria for atopic dermatitis has got major points and minor points. Serum IgE is a minor point in the diagnosis of atopic dermatitis. What is radioallergosorbate test? Now this is one important test which measures specific IgE. It is a test which is used to measure specific immunoglobulin E. What is immunoturbimetry? Or immunoturbidimetry rather. So this is basically a test which is used to estimate serum proteins. It is used to estimate serum proteins which cannot be detected by usual biochemical methods. So this is called immunoturbidimetry. That's why we remain with the last option, which is going to be patch test. So the correct answer for this question is patch test, which is used in the diagnosis of airborne contact dermatitis. So some important basics about patch test. We know that by general knowledge that patch test is used in the diagnosis of allergic contact dermatitis. So this is point number 1. Point number 2, why is it used in the diagnosis? Because it's a type 4 hypersensitivity reaction. So what is this type 4? It is also known as delayed type. It's a delayed type of hypersensitivity reaction. So what do we do in this particular patch test is allergens are applied onto the back of the patient. So we inform the patient about the procedure and we apply the allergens over the back of the patient, and we are looking for the development of a delayed type of hypersensitivity reaction by which we can identify to which substance is the patient allergic to. And when do we take the reading in patch test? So if the question comes in the exam, patch test is red at, then our answer is going to be 48 hours or 2 days. If the question comes as best reading, then the answer is going to be 96 hours or 4 days. So here you can see the reading taken. So by the reading we can easily grade the level of the grading and basically tell the patient as to what severity he has got contact dermatitis or rather allergic contact dermatitis. So please understand, this is for allergic contact dermatitis, not for irritant contact dermatitis. Now the question was mentioning about airborne contact dermatitis. So what is airborne contact dermatitis? This pattern is generally referred to as phytophotodermatitis. Now what is the meaning of the word phytophoto? So phyto means plant, photo means sunlight, and dermatitis means skin inflammation. So dermatitis means skin inflammation. So what is going to happen here is plant chemicals, when they are exposed to sunlight, are triggering inflammation of the skin. So this is called as airborne contact dermatitis. The most important plant in India, which you can see in the image here, which triggers this reaction, is called Parthenium hysterophorus. This plant is termed as Parthenium hysterophorus. And the name of the allergen in Parthenium is also important. It's called SQL, which stands for cis-quiterpene lactone. So cis-quiterpene lactone is the most important allergen which is located in Parthenium. Moving on to question number 8. What is the probable diagnosis of this condition affecting the hair? Now 4 options are mentioned over here. This is a new question which has not been asked previously. So let's take this question in detail. Trichorexis invaginata, Trichorexis nodosa, Trichothiodystrophy, and monolithrix. So first let us try to identify what image has been shown to us. So this image is one of polarizing microscopy. So they have shown a polarizing microscopy image in the exam. And what you see is alternate bands. So you see that there are a lot of alternate bands here. And this alternate bands, what does it resemble? It resembles the tail of a tiger. So you can see the tail of a tiger, which has got alternate bands here. So this is compared to the tail of a tiger. That's why this appearance of the hair is termed as tiger tail appearance. And tiger tail appearance, for all practical purposes in hair disorders, is seen in a condition called as Trichothiodystrophy. So Trichothiodystrophy is the correct answer for this particular question, which was asking about tiger tail appearance. So since it's a new topic, let us learn something more about this topic. So what is Trichothiodystrophy? Now this is a autosomal recessive disease. So this is point number 1 to remember. Now point number 2 is, let us try to split the word Trichothiodystrophy. What is the meaning of the word tricho? Now tricho means hair. This is number 1. Thio refers to sulfur. So whenever there is sulfur compound, you're going to use the word thio. Dis means faulty. Dis means faulty or abnormal. Trophy refers to nutrition. Trophy refers to nutrition. So what is happening in this particular condition is, there is faulty nutrition because of involvement of the sulfur containing amino acids. So what is going to happen here is, once there is abnormal synthesis of the sulfur containing keratin, because you know keratin is the most important protein which is there in the hair as well as in the nails. So we already know from biochemistry that there are 2 important sulfur containing amino acids. So number 1 is cysteine and number 2 is methionine. So both these are sulfur containing amino acids, and these sulfur containing amino acids are responsible for the disulfide bonds. And now we understand why biochemistry is so very important. Once you understand biochemistry, you'll be able to easily understand this topic. So these 2 amino acids, cysteine and methionine, are responsible for maintaining the disulfide bonds, and once these amino acids are deficient, the hair becomes fragile. So hair becomes fragile and starts showing undulation. Undulation means a wavy pattern is seen of the hair shaft, and this is responsible for the tiger tail appearance. So the tiger tail appearance is basically going to happen because of the fragility of the hair. Now let us see, how does a patient of trichothiodystrophy present clinically? So this is the clinical picture of the patient. So first, when you see the hair, what you get an idea is, it is a diffuse pattern. So the pattern is diffuse alopecia, and more than alopecia, what you get is sparseness of the hair. You see that the hairs are sparse and they are broken hair. Right? They are broken hair and sparse hair which start from childhood. And there is an important association which you also need to remember, which goes by the acronym of PIBIDS. PIBIDS. You need to remember the full form of this. So P stands for photosensitivity, I stands for ichthyosis, which we already know is the presence of fish-like scales. The presence of fish-like scales with no inflammation. The presence of fish-like scales with no inflammation is termed as ichthyosis. B stands for brittle hair. The next I is going to stand for intellectual impairment. D stands for decreased fertility and S stands for short stature. So please remember this acronym PIBITS for Trichothiodystrophy in this particular order, and ichthyosis is also a very important question in the exam. Now option A was Trichorexis invaginata. So what is Trichorexis invaginata? This is also a hair shaft defect. So this is point number 1. And why is it called invaginata? Invaginata means going into the next segment. So you can see one segment of the hair is going into the next segment. So there is telescoping or invagination of one portion of the hair into the adjacent portion. This gives it an appearance of ball and socket. So you get a ball and socket appearance here. So ball and socket appearance is seen in Trichorexis invaginata. The word rexis means a rupture. Invaginata means going into the adjacent segment. And Trichorexis invaginata is very important pathognomonic feature of a condition known as Netherton syndrome. So Netherton syndrome, the pathognomonic hair feature here is Trichorexis invaginata. So just for the sake of completion, let me give you the 3 important points which you need to remember about Netherton syndrome, which could be a potential question in the exam. So Netherton syndrome is a triad of 3 important findings. So the first important finding is atopy or atopic diathesis. So atopy is localized type 1 hypersensitivity reaction. Point number 2 is Trichorexis invaginata, which I already told you produces this ball and socket type of deformity. And third important skin lesion here is ichthyosis linearis circumflexa, also famously termed as ILC, ichthyosis linearis circumflexa. So what is important about this particular dermatological condition is it presents as serpiginous migratory lesions. So these skin lesions keep migratory. They have different shapes and sizes, but very important is if you look at the margin or if you look at the scales of this particular condition, you will see that there are double-edged scales. So you get double-edged scales in this particular condition called as ichthyosis linearis circumflexa, which presents as migratory erythematous scaly lesions, and the scales are going to have a characteristic double-edged scale. What is Trichorexis nodosa? This is also a hair shaft defect which you can see can present as nodes along the hair shaft. So the hair is going to break at these nodes resulting in Trichorexis nodosa. The last option was monolithics. Now what is the meaning of the word monily, which means in Latin refers to beaded appearance. So here you get a beaded appearance of the hair shaft. So these were all the 4 important hair shaft defects which I've covered. So this becomes very important for the next exams as well. So please read it in great detail. Question number 9. Identify the type of skin lesion which is shown here. So these are the multiple options: discoid, annular, nummular and targetron. Now when you look at this image, what do you see? You see that this is an annular lesion. You see that there is central clearing. Now this is very important. So this is a rounded lesion with central clearing, and you can see that the periphery is very active. Periphery which is active can be scaly, can be erythematous with a central clearing. So whenever you have this ring type of lesions, when you have ring lesions in dermatology, and when I say ring lesion, I'm talking about this kind of a shape where the central clearing and only the margin is active. These lesions in dermatology are called as annular lesions. That's why the correct answer over here is annular lesion is the correct answer. You can see the prototypical disease over here, which is usually tinea. So most of the tinea lesions are going to be annular. Another important example to remember, especially in association with diabetes, is granuloma annulare. Granuloma annulare. So here you can see that there is central clearing, and you can see the periphery shows a scaly margin. That is why when we do a potassium hydroxide mount in a patient of tinea, we should always take the scraping from the margins. So that is why the margins are going to be subjected to KOH mount, because that is where the fungus lies. It moves outside. That's why it's important to know that the margin is active in an annular lesion. So how do we distinguish tinea corporis from granuloma annulare? Generally, granuloma annulare is non-itchy. It's generally non-itchy, and the most important site is dorsum of the hand. the most important site here is the dorsum of the hand. So that's what we need to remember about annular lesions in dermatology. Now, what is the meaning of the word discoid? That's why this is called as disc and oid. So they are disc-shaped lesions. So they are disc-shaped lesions. Now, discoid lesions are also termed as nummular lesions. What is the meaning of the word nummular? Nummular means those lesions which resemble a coin. So coin-shaped lesions are called as nummular lesions. So you can see that this is the coin-shaped lesion. You can see that there is no central clearing. So this is the most important take-home message here, wherein you should remember that in discoid lesions there is no central clearing and the lesion is active throughout and it has a well-demarcated edge. You get a well-demarcated edge, but most important point over here is there is no central clearing. Example for this condition is discoid eczema. Discoid eczema is the most important example which you can remember in relation to discoid or nummular lesions. Now, another option which was mentioned here is something to do with target. So target lesions are those lesions which have 3 zones in dermatology. So there is zone 1, zone 2 and zone 3. So this is the zone 1, which is the central zone. So point number 1, this is the central zone which is present. Point number 2 is you get a pale zone, which is the zone of intermediate nature, and this has edema. And lastly, you're going to have the peripheral erythema. So periphery, you're going to find erythema in a patient with target lesion. So there are 3 important zones: the central zone, the intermediate zone of edema, and the peripheral rim of erythema. Now, what's the meaning of targetoid lesions? So before that, please remember this point that target lesions for your entrance exam, very very important, is seen in a condition called as erythema multiforme. Erythema multiforme. Targetoid lesions are those lesions which have only 2 zones: the central zone and the peripheral zone, the central zone and the peripheral zone. And the most important example here is Stevens-Johnson syndrome, toxic epidermal necrolysis. This is one important condition where you can get targetoid lesions. Now moving on to question number 10. A child presents to the OPD with tense bulla over the trunk. So the important points to recognize here are: child presents with tense bulla. The level of blistering on biopsy is subepidermal. And the most important point to remember here is there is neutrophilic infiltration. What is the management of this case? Rituximab, dapsone, cyclosporine, azathioprine. Now, when you try to analyze this question, as I've already mentioned to you, there are 4 important clues here. So we need to fit into a particular diagnosis. So there's a child in the question, tense bulla, subepidermal split, and neutrophils. So which disease are we talking about? So once you say subepidermal split, automatically pemphigus is out. So now, among the subepidermal blistering disorders, which one is usually seen in children? The diagnosis becomes CBDC. So CBDC stands for chronic bullous disease of childhood. So chronic bullous disease of childhood is the diagnosis. And CBDC is one disease which is mediated by immunoglobulin A, and it's more common in children. And if you watch the videos, you would have already been familiarized with this pattern which you get in CBDC, where there's arrangement of lesions in the form of a cluster of jewel. That's why it's called as string of pearl appearance, also known as cluster of jewel appearance, also known as cluster of jewel appearance. So these are the 2 important appearances which you need to remember for CBDC. But one thing which I want to tell you about this particular question is, even if you had not figured out the diagnosis, for instance, you have not figured out that it is CBDC, still with the question you can answer it correctly, because once you see neutrophil, the drug which can inhibit neutrophil chemotaxis has to be dapsone. So dapsone is the answer because it can inhibit neutrophil chemotaxis. And this reason I've already mentioned when I was discussing dermatitis herpetiformis, because you know that in dermatitis herpetiformis also you get neutrophilic infiltrate. That's why the drug of choice here I've already mentioned as dapsone. So the logic over here is because it inhibits neutrophil chemotaxis, that is why dapsone becomes the answer. What about rituximab? Where do we use rituximab in dermatology? So we know that the B cells have got an important marker called as CD20. And rituximab is going to block this CD20 marker which is located on the B cell. So rituximab is FDA approved in the management of moderate to severe pemphigus vulgaris. So in the management of moderate to severe pemphigus vulgaris, we use rituximab as treatment modality. But pemphigus is ruled out. So what are the points which rule out pemphigus? Number one, tense bullae. So please understand, pemphigus is a superficial disease. It is going to present with flaccid bullae. So this is point number one. Point number two is, we already know whenever the word pemphigus comes, you have to remember superficial disease. You remember that it's an intraepidermal disease. So whenever there is a question about intraepidermal, any disorder which is intraepidermal in the bullous disease chapter will definitely have the word pemphigus in the description. So could be IgA pemphigus, pemphigus erythematosus, paraneoplastic pemphigus. Whenever there's a word of pemphigus, you have to remember it has to be intraepidermal. That is why the correct answer in this condition, because neutrophils are there, you can obviously go for dapsone as the correct answer here. Now another question which was asked in the exam, a young female presents with fatigue and hyperpigmented knuckles. So whenever there is hyperpigmented knuckles and there is fatigue, the examiner is talking about a patient with anemia having hyperpigmented knuckles, and this is a very characteristic feature of which nutritional dermatosis. So please understand, once again I want to tell you is nutritional dermatosis is very important, right? And the correct answer here is B12 deficiency. So in vitamin B12 deficiency, you're going to have anemia with hyperpigmented knuckles. So how does vitamin B12 deficiency present? It is going to present with glossitis, and this is also known as beefy red tongue. Presents with beefy red tongue, and here you can see the knuckles, the knuckle pigmentation which is seen. So knuckles are going to show hyperpigmentation. And many times when students also come to us with premature graying of hair, we do vitamin B12 levels because this is termed as canitis. So what is canitis? Canitis is premature graying of hair. Premature graying of hair. And one important vitamin which has been implicated in premature graying of hair is vitamin B12. Now another important vitamin deficiency which keeps coming up in the exam is pellagra. You should know that pellagra is B3 deficiency, and here the amino acid which is involved is tryptophan. So tryptophan metabolism gets involved here. And what is the triad of pellagra? Number one is dermatitis. Number two is diarrhea. Number three is dementia. So dermatitis, diarrhea, dementia are the 3 Ds of pellagra, but please remember dermatitis is not good enough, because you need to remember what type of dermatitis you're going to get. If you look at this picture, what you see is a Castle's necklace, and this necklace, where is it distributed? What kind of areas are getting involved here? This is termed as photodermatitis. So photosensitive or the photo-exposed areas get involved. This is known as Castle's necklace. This is termed as Castle's necklace. Another important vitamin deficiency which you need to remember is riboflavin deficiency, and we know that B2 is riboflavin, and what you see here is the nasolabial dyssebacia. So point number one, get nasolabial dyssebacia, that is abnormal sebaceous gland activity in the nasolabial fold. In the oral cavity you can get angular cheilitis and glossitis. Angular cheilitis. The tongue which shows inflammation, which is called glossitis, has a special name. This is called as magenta color tongue. And the eye, especially the cornea, you can see a very nice image here where the blood vessels are climbing onto the cornea. This is called as corneal neovascularization. It's termed as corneal neovascularization. So many times this question can come in the exam. Corneal neovascularization is implicated in which vitamin deficiency? The answer is going to be B2 deficiency. And this is also a very important disease which is pertaining to zinc, which is called Acrodermatitis enteropathica. We should know that it is an autosomal recessive disorder where the zinc uptake at the level of the intestine gets affected there because of the transport proteins and uptake proteins there. And what is the triad of Acrodermatitis enteropathica? Number 1, dermatitis. Number 2, alopecia. And number 3 is diarrhea. So dermatitis, alopecia and diarrhea, these are the 3 important points for the diagnosis of Acrodermatitis enteropathica. And please look at the dermatitis. What is the pattern of dermatitis you are seeing? So number 1, it is periorificial. That is, it is located around the orifices, around the eyes, around the nose, around the mouth. And the second pattern is the acral pattern. So acral dermatitis. So periorificial dermatitis and acral dermatitis, both these patterns are very important for the diagnosis of Acrodermatitis enteropathica, and the treatment for this condition is lifelong zinc supplementation. Lifelong zinc supplementation. Lifelong zinc supplementation. And this is yet another important vitamin deficiency you need to remember, which is scurvy, which results due to vitamin C deficiency. And here what you observe is the presence of perifollicular hemorrhage. So point number 1 is perifollicular hemorrhage. So this is point number 1. These are all very characteristic features because bleeding gums is known to everybody, isn't it? For entrance exam, you have to remember the high yield points. For scurvy, it is perifollicular hemorrhage. You can see the hair here, and this hair is termed as corkscrew hair. So this is termed as corkscrew hair. So 2 important features for scurvy. Number 1, perifollicular hemorrhage. Number 2 is corkscrew hair. Now, just to summarize the important high yield topics in dermatology, which I've already discussed previously as well. So, infections is very important. So, integrate it with microbiology. Don't run away from micro because micro is going to fetch you a lot of marks in the exam. So, usually there is one question from bacterial infections, viral infections, fungal infections, parasitic infections. So, nowadays fungal infections are very important. Antifungals is a very important topic for pharmacology as well, because obviously we easily can identify what topics are important for the exam, because in OPD we see so many patients coming with fungal infections because of the inappropriate usage of mixed creams, which is common among students as well. So always see that, try to avoid these mixed combination steroid containing creams. That's why fungal infection is important. STDs, we have already seen in this particular exam 4 questions have come. Usually 2 to 3 questions are 100% sure from STDs, so please do it well. Leprosy is yet another important area where you need to identify the spectrum, and the treatment of leprosy is important. In papillosquamous, it's important to do psoriasis well. In bullous diseases, you should do pemphigus vulgaris well, bullous pemphigoid and dermatitis herpetiformis. You should have a concept of bullous disease because one question usually comes from bullous disease. In eczema, the important topics have to be, one is contact dermatitis, atopic dermatitis, and patch testing. So these are some important topics which you cannot afford to miss. Especially atopic dermatitis is very common and frequently asked question in the exam. Then in the appendages and disorders, hair is an important topic. In pigmentary disorders, vitiligo and melasma, these are some important topics. And skin and systems is very important. I already discussed nutritional dermatosis with you. Connective tissue diseases, SLE, dermatomyositis, scleroderma, you should know the important skin manifestations. And in genodermatosis and neurofibromatosis is very important. Neurofibromatosis, tuberous sclerosis complex, and Sturge-Weber syndrome. So these are some genodermatosis which you should know in and out before going for the examination. So now we move on to the last segment of this video, where we'll be discussing those issues which are been troubling a lot of students. So first is the news of the postponement of the exam and changes which have been suggested in the internship schedule as well. So what is this? Is it a good news or a bad news? Please understand, there is just news. There's nothing like good news or bad news, because once as a student you tend to attribute a lot to a news, it can adversely affect your timing and preparation. The second issue is, does this postponement make sense? Because we tend to logically try to analyze each and every news that we come across. Yes, most of the students would say it does not make any sense. But please remember, in life, not everything does make sense and not everything has to make sense as well. Students who've been preparing for more than a year can definitely feel there is a lot of time still which is remaining, and you may tend to waste the time which is there at your hand. Please remember this important attribute of time. Time is just an illusion. There is only the now moment which is there, which you need to use maximally. At the internship level, students may feel that there is less time and so much more to study. For them, it is not about how much we have lost, it's about how much we are left with. So make use of each and every second which is there in your hand whenever you're doing your ward work and whenever you have free time. Especially QBank is a very important tool which you can use to flip through MCQs and go through important topics. Some students may feel they've started too late. Could be because of internship schedule, could be because few of the students were working, could be there was a health related issue in the family or personally. So for such students, please remember, though no one can go back and make a brand new start, anyone can start from now and make a brand new ending, because finally all of us want to end well. For that, it's important that you start right now so that you move towards your goal ahead. A lot of students who've been confused, especially after the AIIMS exams. The exams have not gone well, so they do not know what to do now, how to go about things for the NEET exam. So for them, what you need to remember here is one important attribute of the mind. So the mind is like water. When it is agitated, it becomes difficult to see. So similarly, what you do is, once you settle down, the answer becomes clearer. So you need to take a deep breath, relax, and the most important thing right now which you need to do is plan. So when you're going to plan, what are you going to do? You're going to focus on three important areas according to me. So number one is, focus on those areas which are always been difficult for you to remember. There could be some topics which have been left half done. So some of the topics may be done partially, or could be some subjects are difficult for you. Right now, work at it, because it's important that for the NEET exam, in order to do well, you should have no weaknesses. So work towards these weaknesses and transform them into your strengths so that you get you do well in the exams. And revision of the notes is also very important of whatever you've already made. And see that 30 to 40% of the time is devoted in solving MCQs. You can either choose questions from the QBank or from the grand test to do so. Another complaint which most of the students have is that their GT performance have been stagnant. So what are the things you can do about this? Number one, work on your weak areas. So how are you going to analyze this? Via GT analysis, you can easily make out which subjects have been weaker for you, which subjects have been stronger for you. So work on your weaker subjects. And further, if you have more time, you've done everything right, still you're not able to hike up. So what you can do is you can watch the revision based videos and the MCQ based videos which are there in the Marrow app. So first what you do is, don't watch all of them. First you focus on those areas which are weak for you. Do the weaker subjects, revision and MCQ based videos first, and then if time permits, you can go for the other subjects. And if you see, most of the students have made a lot of silly errors in the exam. And some of the students have not read the question properly. That's why they've got the answers wrong. And some of the students have been able to leave almost 30 questions they have not been able to complete in the exam. So time management is also important. So see that GTs and exams are taken seriously and follow a proper time schedule for it. Some of the students are not sure what type of questions are going to come, what is going to be the pattern of the exam, what is ahead in life for them. So please understand one thing about life, that yesterday is history, tomorrow is a mystery, but today is a gift, and that is why it is called as the present. So live in the present moment, enjoy the present moment, and see that you do your best in the present so that you have a bright future ahead. So with this, I wish all of you all the very best for NEET 2021 exam. And please remember, the harder you work, the luckier you get. Thank you.